Doctors, nurses, and scientists and others have struggled to understand how to care for those who have been infected with SARS-CoV-2. Hopes for a novel or a repurposed treatment suddenly soar, only to be crushed under the weight of evidence. Yet with painstaking accumulation of knowledge and the prospects for treatments have improved. Even as slow progress has been made, the public has often been left confused by the changing state of science, making accurate, reliable journalism all the more critical. Today, we'll hear from three top experts who will take us onto the pandemic's front lines, explain how the treatment has evolved in the last 8 months and where it's headed, and what it's like to face the challenges of reporting on an incredibly fast-moving science and treatments during a pandemic. Each of today's panelists will speak for about 10 to 15 minutes, and then we'll move into a Q&A session to answer as many of your questions as we can. Following the panel, the experts will be in breakout rooms for some additional conversation. And now to the panelists. Amish Adalja is a senior scholar at the Johns Hopkins Center for Health Security at the Bloomberg School. He is an infectious disease physician who works on pandemic policy, emerging infections, and preventing bioterrorism. He has served on U.S. government panels that developed guidelines for the treatment of plague, botulism, and anthrax in mass casualty settings, and for the system of care for infectious disease emergencies. He also practices infectious disease, critical care, and emergency medicine in the Pittsburgh area. Amish will discuss the evolution of COVID treatments and future directions of medications and approaches to patients. Lisa Hurst is the nurse manager of the Johns Hopkins Biocontainment Unit at the Johns Hopkins Hospital. She leads a staff of 30 nurses who collaborate with critical care physicians, infectious disease specialists, and infection control epidemiologists to provide care on patients on the unit. She is a past president of the Maryland Nurses Association and was instrumental in promoting legislation to increase penalties for assaulting healthcare workers in the state of Maryland. Nasa will take us inside the hospital and discuss how hospital care has adapted, what it's like for nurses taking care of COVID patients, and the issue of PTSD among nurses. Apurva Mandavelli is the science and global health reporter for the New York Times. And before joining the Times, she was founding editor-in-chief of Spectrum, a news site on autism science. Her work has appeared in The Atlantic, Slate, The New Yorker, and Best American Science and Nature Writing. She received the Victor Cohn Prize for Excellence in Medical Science Reporting in 2019 and is a co-founder of Culture Dish, an organization dedicated to enhancing diversity in science journalism. Apurva will share her reflections on what it's like to report on the pandemic and its rapidly changing treatment landscape, finding sources, and dealing with preprints and other challenges. And with that, we'll now move on to our first speaker, Amish Adalja. Thank you.
I thank you for that introduction. So what I'm going to talk about is my role as a treating clinician, and I think I may have a unique view because many people in my field that work in pandemic preparedness or even that work at the Center for Health Security aren't actively seeing patients, and I've been seeing patients throughout this pandemic, at least 50% of my time, even just Saturday and Sunday, I was taking care of COVID patients. So it gives me a kind of a unique perspective because I see what goes on in Washington, I see what's going on nationally, the WHO, the CDC, and I talk to a lot of press people like Apurva all the time. And then I also have to take care of patients. So I kind of get that I toggle between both roles simultaneously. So I do think it kind of gives me a little bit of a unique experience, and I get my own unique frustrations because I know what things could be or what they couldn't be. So what I'll do is try to take you kind of through how I've been approaching treatment since the beginning of this pandemic. So I remember thinking about the pandemic in January when we first started hearing about these cases and wondering, are there cases here mixed in with our flus? That was something I was suspicious of. But my first official patient was around mid-March or so. It was in a community hospital outside of Pittsburgh in my hometown. And it was the first she was diagnosed. So at the very beginning, we were unable to diagnose patients. And I think this is something that's really important to remember is that the CDC screening criteria meant that you had to have been, when you tried to apply, it had to have been to China and you had to have had lower respiratory tract involvement. You couldn't have just had a sore throat and get tested. So I know that that my real first patient was really probably my sixth or seventh patient because I missed a lot of them because I was unable to test them because we couldn't get the test approved. But my first patient, I can remember on oxygen and needing breathing treatments, the bronchodilators that we give people with asthma. And at that point, we didn't have any treatments. It was all quote unquote supportive care, which might sound like nothing when a journalist says, well, what's supportive care? That doesn't sound that interesting. Or people say that's not, but it is. It's monitoring them oxygen, it's IV fluids, it's checking their electrolytes and replacing them. But this was around the time when hydroxychloroquine was a little bit in vogue, and we had some mixed data that was coming out. So many hospitals were using hydroxychloroquine as part of a protocol for hospitalized patients. So my very first patient did get hydroxychloroquine for a brief period of time. So that's what we were doing. We didn't really have any data, so we were trying to extrapolate the best we could from research, talking to colleagues, and from other conditions similar to it. And that's initially what we were doing. A little bit of hydroxychloroquine whenever it fit into a hospital-based protocol. And then rapidly the data started showing that hydroxychloroquine didn't work, and more and more clinical trials started to be published, and hydroxychloroquine basically faded away. But in its place came a drug called remdesivir, and I think that was something we were initially very enthusiastic about using. We thought this might be something that will change mortality, that it will be something that we can use on a lot of patients. But then the data started showing, well, remdesivir, you have to give it early. If someone's on a mechanical ventilator, if someone has high levels of need for oxygen on BiPAP or CPAP, it's not going to work. And it's not going to change whether or not they live or die, but it might get them out of the hospital a little bit quicker. So we quickly had to try to adapt to use remdesivir. And at least in the Pittsburgh area, we never had major remdesivir shortages. I know there were shortages all around the country. We tended to have plenty of remdesivir, and the process wasn't very difficult to order. It was something, this is under the emergency use authorization. We could do it pretty quickly with a few phone calls, and it was dispatched. And it may have been because I was practicing in Western Pennsylvania, which was never inundated, even at the worst of times. And we have plenty of supply. We have big academic medical centers here that kind of facilitated a lot of the remdesivir use. But that's what we were still in the dark, again, whether or not, when we didn't have the granularity to say, when should we use it? We knew we can't use it too late, but how early should we use it? Does everybody that requires hospitalization need it, or is it just people with oxygen? So that's kind of what a clinician has to go through. It's not cookie cutter medicine. It's not like you see this approved and then all of a sudden everybody gets it. You've got to think, how does this actually apply to my patient? And where does my patient fit on the spectrum of illness? And I don't want to give them something unnecessary, and I don't want to give something too late. And I think that's still a challenge with remdesivir. Dexamethasone came, and I think that really was embraced very, very well because of all the data that accompanied it, that it was decreasing mortality. And dexamethasone became a major part of how we treated patients who needed oxygen in the hospital. It got overused, I think, because now we also saw primary care physicians using dexamethasone for anybody that had COVID or COVID-like symptoms. And we know from the data that if you give dexamethasone too early, if you give it to people who are not hospitalized, who don't need oxygen, you can actually make them worse. But that's still continuing today, which I think is also something that's an important theme as well, is when a new treatment comes out, people will often use it outside of where it actually was proven because they haven't taken the time to read the studies, or they're just trying to extrapolate on their own from the studies without really any basis to do so. Convalescent plasma was another one that was kind of a tricky drug. And again, it faces the same uncertainty that we have with remdesivir. We don't know who it works in and when it works. And what happened with convalescent plasma is there were clinical trials going on, but then there was something called expanded use that the Mayo Clinic offered this product to hospitals that were part of their big web that they were reaching into, and you could get it pretty quickly and pretty easily. But I had no idea whether or not it was working or who to use it on in my patients, and there wasn't any real guidance, and I don't think there really still is. And I know there are major advocates like Arturo Casadevall at Hopkins who really have advocated for this. But as a clinician at the bedside, it's hard for me to know who needs it and how strong the antibodies are in convalescent plasma because we have no way really of telling how much is in there. So it came, and then when the emergency use authorization was pushed through, because there was a lot of perception that politics played a major role, many clinicians stopped using convalescent plasma because it wasn't something that they thought really was justified with all of the paperwork you had to go through, and then you saw that it got politicized and we didn't have any real guidance on how to use it. Some of the other things I wanted to touch on were the fact that treatment in the early stages, this is kind of a little bit of inside baseball about how we dealt with patients, but a lot of hospitals had protocols, and and maybe NASA can talk to that. If someone was on a high level of oxygen, so maybe 6 liters, which isn't really that high, we have lots of people with emphysema that are on 6 liters. But if they were on 6 liters, there was a rule in some hospitals. We just want to put these patients on mechanical ventilators and intubate them because we don't want to have what would be called a crash intubation when they're circling the drain and you have to do it very fast and you're more likely to get exposed. All of that really has faded away, and we've gotten much better at managing the oxygen needs of our patients. We weren't even using BiPAP and CPAP early on in the pandemic, which are non-invasive forms of ventilation, because we were so worried about the virus aerosolizing. But we've gotten much better at using BiPAP, CPAP, high-flow nasal cannulas, and only using ventilators when we need to, because we've always known that ventilators cause lung injury, and you don't want to put people on ventilators unless you need to. We also learned about putting people on their stomach, even when they're not on a ventilator, because it helped their oxygenation. So that's also become something that's really standard now. And we've gotten much, much better at complications. I can remember in March taking care of patients and not knowing when they were decompensating, if it was because they were going into a cytokine storm, if they developed a secondary bacterial pneumonia, or if they had a pulmonary embolism. We've gotten much better at understanding how to recognize, prevent, and treat those complications. So that's also given me a lot more confidence. So I took care of so many patients over the weekend, and it was almost becoming protocolized in my mind the way I was dealing with these patients, because I've seen so many of them now, and there's so much literature that's come out, so we've gotten much better. Just a couple of little other things to talk about. The immune modulators, people talked a lot about this cytokine storm. We still don't know how quite well to treat it. There have been some drugs that have been out there that when people get into the last throes where their immune system is very dysregulated, we don't know what to do in those situations. There are a lot of clinical trials for drugs that have been repurposed from cancer and other conditions, rheumatologic conditions. Not a lot of data to guide our use, so that's something that kind of happens on an ad hoc basis, and we need more clinical trial data there. Lastly, one of the things that's come out in the last week is the monoclonal antibody. And I just want to say that this is going to be a challenge to see how it's implemented. And I think there will be lots of good stories for journalists to try and see how hospitals implement the use of the monoclonal antibody from Lilly, because this is something that if you give it to someone when they're hospitalized, it's too late. And you need to give it to them when they're diagnosed. So how are hospitals and how are communities going to be able to set up infusion centers to give this drug? It looks promising. We've seen the president got a similar type of drug, and former Governor Christie got this drug. But we don't know how to come up with a concept of operations on how to give this to people. Do you have an infusion center attached to your emergency department? Do you keep them in the emergency department for the hour plus or so that it needs to be infused? I think that's the other part of it. It's not always just that we get this fantastic new drug. There's a lot of downstream consequences of how we actually implement it into a process of care. And I think that's also that's something that's underappreciated, that we don't know how we're going to use some of these drugs. And I think that if this was an oral drug, it would be great, because then this would be so easy to administer, but it's not. So I think that we have to also think about not just developing the drug, but developing a concept or developing a whole procedure about how it's going to be infused, how it's going to diffuse, how we're going to actually gain the value from it. Because right now, I don't know anybody that's giving it, and I think it's going to be a difficult challenge to figure out how to catch these people soon enough to give them this drug. So I think that's basically what I wanted to tell you in my overview. I think it's been a whirlwind of changes, and I think I've never had to keep up with a field or a disease this much, not only to be able to inform all of you when the press calls me, but also to take care of patients. And it really does change on a minute-by-minute basis. And I think it's exciting as an infectious disease doctor to be doing things as they're happening, but it is very hard to keep up and very tiring. And and I think we still need more tools. And I think we will get there eventually, and treatment will evolve to a place where everybody can handle these cases a lot better than they do today, even. But it is still we still have a long way to go, and there's a lot more patients that we're going to be treating in the months ahead. So thank you.
That's terrific, Amish. Thanks so much. And we'll move right on now to NASA. Thank you, NASA.
Well, thank you. To follow up on some of the things that Amish mentioned, everything is evolving. The hospitals, they use a concept of what I refer to as plan and pivot. And that's been since, I would say, January. I've been involved in this since January 24th, I was actually at the School of Public Health in the Health Emergencies in Large Population class for my doctoral program. They talked about this outbreak in Wuhan, and they wanted to see what it was going to be like. And the comment was made, we're going to follow this. And we're going to follow this to where we are today is such a journey. The hospitals in a good setting, and again, my experience is what I've seen at Johns Hopkins. I haven't had the opportunity to work closely with a lot of hospitals day to day. We've certainly had a lot of communication. I was actually on the phone with Sydney, Australia last night about their biocontainment unit. But hospitals that can do this well have to have a synergy between clinical and operation. And it's just like Amish said, infusion is a great idea. How do you put it into practice? We also have to see a lot of really good data-driven operations. And I think that we've gotten some really good information through a lot of our healthcare providers. Bloomberg School of Public Health has been a real big player in this process, giving us some real data about what do we do? Does convalescent plasma work? Does it not work? Because those are a lot of the decisions that you really have to make in the minute. There's also a balance between competing priorities. And this is where leadership really has to get in there and really get in the game. Because one of the things that the staff will always say is, I'm getting these mixed messages. So for leadership to get together and have one simple message that we're going to continue on is really important. Communication is also front and center, and not just sending out emails. We talk a lot at Johns Hopkins about communicating 6 times, 6 different ways. It's part of the reason that I've gotten involved so much with the press, because I really think that as journalists, you play such an important role in this process. We learned a lot in the beginning. We sort of had to follow just what, the command center told us to do. And I've talked to staff about that because it's a different response than what we're used to. Especially, our nursing organization at Johns Hopkins is a lot of what we refer to as shared governance. So we can make a lot of decisions independently in our units. And that all went away pretty quickly. And that's a big culture change for a lot of people. And so by the time I had staff actually leave our unit in March and not come back until July, some of them not come back until August. And that's significant. These are in the endoscopy unit that I run, separate from the biocontainment unit. There are people that have been there for 30 years. Their only experience has been in that type of operation. So to take them and put them into a different place required an awful lot of work and a lot of communication. But we had a lot of lessons learned. One of the things we learned from the last go-round is that this instant shutdown of operations doesn't necessarily help patients. It's what we had to do to respond, but right now we're looking at a lot of different alternatives, one of which is more of a ramp down than a shutdown. And that's important because it gets a message out to patients as well. We're talking about, looking at cutting surgeries and endoscopy procedures anywhere from 10 to 30%, again, to allow for this buildup in our bedside. Nurses, one of the things, and I said this on Bloomberg News one day, that, there's one thing that we learned through this pandemic is how important nurses are to the healthcare system. A lot of what Amish talked about, it's great to have a physician's order, but if there isn't a nurse at the bedside who's actually administering the remdesivir and watching the patient's reaction to this response and monitoring those vital signs, then that patient's not going to have a very good outcome. And the backstory to that is, and we learned this in my Bloomberg class, was that this has moved from a public health event to a disaster preparedness event. And if you don't have nurses that are going to support the surge, then you're not going to have a good outcome for patients. So it's really, really important to start that work, which we did at Hopkins very early, and to continue that work. And so what's it like in a day-to-day situation? You have to have a mind shift. You have to shift from a specialty outlook to being able to manage a COVID patient. And that was huge for us. Amish talked about, getting some of these things very protocolized. They are very protocolized. We have about a 28-page protocol of how to manage a COVID patient. And that's what the nurses are responsible for doing. I had to talk to a lot of staff. We are not here to learn about wound vacs after 30 years. We are here to follow this protocol, administer this remdesivir, the convalescent plasma, do the proning, monitor the vital signs in a very specific way to help this patient recover from COVID. The problem with that is that nurses are trained to look for defects. So we're all about finding the problem first, before the problem even happens. And so that's another mind shift that we have to go from. We have to go from looking for the problem to having some level of trust. And that trust comes with training. And that trust also comes with saying, look, I'm not expecting you to be an endoscopy nurse in the ICU. I'm expecting you to be a competent nurse who can manage a COVID patient. And that, again, has been a very difficult mindset. One of the things that we have done is start that planning now. All of the staff are trained at either a telemetry level, an IMC level, or an ICU level. And we're using some technology that we didn't use in the past to say we have 40 nurses that are trained in telemetry that are available to go out to the units. We may need 40 ICU nurses, we may only have 16. And then how do we pivot from that point? In other words, using a pod model where you might have one ICU nurse followed by 2 or 3 IMC nurses. Again, these are some of the things that we have worked out over the past few months, and we're going to see more and more of that. Our system, we have a sort of call today, and we talked about making sure that all of your staff skill sets are in, because when we flip the switch, that's going to give us what our availability is. And we didn't do that really well in the beginning. We did a lot of pencil and paper type of things, so we're moving from that. What's happening inside hospitals? I spoke about ramp down versus shutdown, and that's very important. We are looking at the numbers every single day. We have this magic number. When we hit this many patients, that means we're going to drop from 60 cases in endoscopy a day to 40, and then we're going to send this many staff out. We also talked about reducing inpatient admissions, and that's significant. The demand that we're seeing this go around is much more of an acute care versus an ICU level. That can change almost overnight. And so what we see in a lot of cases is a patient coming into the emergency room, and we may have admitted them in the past. We're just not going to do that today unless that's the right thing to do for the patient, because we've got to preserve those beds, because we see these numbers increasing every single day. The other thing that we talked about, and we just spoke about it this morning, is being surge savvy. And surge savvy means that we are having very robust conversations with our staff about no meetings larger than 10, no holiday potlucks that are, really common in the hospital environment, not traveling for the holidays. And we have a lot of leaders that have stood up and said, look, I am not going to be going home. That's not the right thing to do this year. And that makes it easier to have those conversations with employees, because one of the things that's pretty consistent is that in order for us to have any foothold in this next surge is to change our behaviors. Staff need to have a lot of access to information. And again, not just a lot of emails that go out, but a lot of rounding from leadership to be able to ask those questions. One of the things that I've learned with both the BCU staff and with the endoscopy staff is to say, look, I don't really have any new information from yesterday, but we're going to have a brief meeting anyway, so that the information is always coming forward. Just-in-time training, we did a good job of that last time, but it's mission critical in this space. And because we trained people before, now we have a little bit of a broader base, but it's still a battle. The thing that's most challenging about this epidemic is the psychological toll. You can't seem to get past the isolation. We're having more and more community patients out in the community that are recovering from COVID. There have been some studies to talk about that those patients significantly suffer from depression and anxiety related to COVID. Perhaps, again, the data is not necessarily really clear on that. And now we're seeing a lot more staff who are contracting COVID because COVID is out in the community. We're not having the patient-to-employee transmissions, and I want to be really clear about that. Our PPE works, and our PPE works well. What, again, we're seeing is these transmissions from the community. And so now we're going to have a next wave of care providers who are faced with their own psychological stress, perhaps magnified by this COVID impact. And that's going to be interesting to see. I know Cinda Russian has been involved with this organization, and she has always been a key thought leader in how to build resilience. But the human skill of building resilience is just as important as the human skill of learning how to make sure that you're competent in caring for COVID patients, because that resiliency is an incredibly important skill set. We work on that daily with our staff. Staff need to feel like the organization has a plan and can protect them and can provide for them. And so our closing message is that, changing behaviors, changing our mindset, changing our training, changing the way we look at new practices. I agree with Amish, not just taking every new toy and taking it out into the community, but really having some thought in this is really what's going to be important with all of us. I personally am a big Winston Churchill fan, and I've spoken to my staff, a lot of times about never, 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 never give up. And that gets harder, right? We've been doing this since January. But Churchill said, there is no time for ease and comfort. It is time to dare and to endure. And I think that's very important with all of us. Thank you for this opportunity, and I look forward to your questions.
Great. Thank you, Nick. And we'll go to Apurva.
Just wanted to say that I am going to talk about my experience with all of this as a journalist. You've heard from Amish and Nisa about their experience as healthcare workers and as experts. And as a journalist, it's been really quite complicated and challenging at times to figure out which experts to talk to, what to cover, what to believe, what not to believe, where to look for information, and to really be able to weigh the information and see what readers need to know about, what they probably shouldn't know about because it's not credible information. And overall, I would say a lot of time in this pandemic has been spent debunking and setting things straight. So in the very early days, the news was just coming so fast. And as you all know, a lot of it was coming out of Wuhan. There were these preprints and journal articles that were just being rushed through about characteristics of people who get really sick or characteristics of people who die and who doesn't seem to get so sick. And as we were getting more and more information, we had to really revise what we knew about risk factors, what we knew about who should be worried. So a lot of the early reporting was on things like obesity is a risk factor, old age is a risk factor, being male is a risk factor, these things that would inform clinical practice, but in the US, but we're also coming pretty much from straightforward clinical observations in Wuhan. And in some ways, it wasn't clear how much would be easily translatable because China is a very particular place, and the way that they handled the pandemic, their epidemic, is very different than how we've done things. But we still, I think, benefited a lot from having information from both China and from Italy early on. In terms of treatment, one of the things that came out early on from Italy especially, but also from China, is that IL-6 inhibitors might be important. So IL-6 is this cytokine that's released by immune cells. And this idea was basically that in some fraction of people, the immune system isn't able to contain the virus. And in trying to contain it, it sort of ramps up more and more until that runaway immune response, that runaway inflammation is actually more dangerous than the virus itself was. And I think this is actually still a very popular theory, although it's now no longer goes under just cytokine storm. We just know that the second week of COVID is more dangerous because that's when the sort of inflammation kicks in and the body trying to contain the virus almost becomes more dangerous than the virus's initial effect. So when use of IL-6 inhibitors was first coming out, I wrote a couple of pieces about cytokine storm and the possibility of IL-6 inhibitors. And even then, it was very important to talk to the right experts, which is a huge message for me throughout this epidemic and reporting on it, is that not all scientists are the same, not all doctors are the same, not all expertise is the same. And so it was very important to me to talk to rheumatologists who actually deal with drugs like IL-6 inhibitors, hydroxychloroquine. Almost all the drugs that we tried early on are actually drugs that are used in rheumatology to treat rheumatoid arthritis and lupus. And so rheumatologists have a lot of experience with these drugs. And so I talked to some of them, and it turns out they were skeptical right from the start that something as specific as an IL-6 inhibitor may not go that far in a disease like this, because you actually need to control the immune system in a much broader level, not just targeting one molecule. And sure enough, I think their hunch has proven right, which is that IL-6 inhibitors haven't actually proven to be very useful in clinical trials that have been done. And in fact, what's useful is the drug that Amish referred to, Dexamethasone, which has been around forever, and it's a very broad-acting steroid and immune suppressant. And to be quite honest, I don't think that we would have known that if we were just relying on U.S. research, because that drug was really only proven to be effective in the UK recovery trial. Similarly, the WHO has looked into a lot of things that maybe pharma companies would not really be motivated to look into, because something like dexamethasone isn't going to make them much money. And so I think as journalists, that's the sort of question that we have to be asking is, are we only testing all these IL-6 inhibitors like Actemra, which is made by Genentech and Roche? Are we only testing those because they happen to be around and they're approved and they will make the companies a lot of money, and the companies have the wherewithal to launch quickly a phase 2 or 3 trial and do the kind of vetting that a drug that nobody has invested in yet is going to be really hard to test. So that's been a really important thread throughout, is to ask, as we, journalists all know all the time, follow the money. Where is money making the decisions about what's getting tested and how? Also, I would say early on, even though we wanted to speak to the right experts, for me at least, it was extremely difficult to get to talk to doctors and healthcare workers in general, to nurses. I was working on a pregnancy story back in April, and it was impossible to get through to the doctors who were actually working on the cases. They had published a study, but there was just so much fear around liability and around getting in trouble with the administration of the hospitals, that a lot of hospitals had just, no press rules, which made reporting incredibly difficult. I did some interviews on background and off the record, but it was very, very hard to get people to talk on the record. And thankfully, as we went on, that changed a little bit, and we were able to have access to some physicians who actually had frontline experience and could talk about what they were seeing. But, I would say it's still difficult, especially at times when people are seeing a lot of patients, to ask them not just to take the risk of angering their administration, but also taking time away from patients and from clinical care. If I recall correctly, I think at least one interview I did with Amish was when he was driving, and then he got home and he was in the garage, and then he went to his apartment. It was like, I really appreciate doctors and scientists who have taken, time in all little corners of their life to be available to the press. I think it's been incredibly helpful. And as probably many of the journalists here know, when we went into the lockdown, it was really hard to even know how to contact a scientist other than by email, because all of a sudden we didn't have access to their phone numbers because nobody was in the office. And so it became really important to cultivate sources who were willing to part with their cell phone numbers, or who were actually going to be looking at their emails on any kind of regular basis. And if that was a doctor or a healthcare worker, chances are they weren't going to be doing that because they were actually working and not looking at their phones. So it really did change the way that we report on something like this, where when you actually need very clinical information, you may not have access to the right clinical expertise to answer those questions. As we went through the pandemic, it got a little bit easier to report on a lot of different things. Where I've done a lot of reporting is really on the sort of more basic biology of the virus. And the thing that I have tried to stick to throughout is to really put into context what is really unusual about this virus and what is not. I think this virus is new in many ways. I mean, obviously, it's brand new to all of us in terms of our bodies, and it is a pandemic that we've never lived through, and so it's natural to want to see it as this unique and bewildering monster. But really, when you look closer, it's not really that different than any other virus, and our body isn't reacting to it any differently than with any other virus. It's just a more extreme version, more severe in some ways, but the immune response, for example, is exactly as it is to other things. And even the drugs that we have seen be effective, it's very similar to what we would expect. Not a surprise to anybody who actually paid attention to the biology that hydroxychloroquine would not prove to be effective. Not a surprise to anyone that remdesivir might only be useful in people who are at a certain stage of illness. It's as if in the panic and in the rush, and to be fair, the lack of treatments, we tried a lot of things, and we were forced to, doctors were forced to try a lot of things, but ultimately, the biology is really what's going to prevail in how we treat this virus and the disease. Amish brought up monoclonal antibodies, and I think that's another example of where, we've used monoclonal antibodies in lots of different diseases, very rarely with infectious diseases, mostly with cancer and, again, with autoimmune diseases. But we have some knowledge there, and it's been distracting to have certain political leaders talk about monoclonal antibodies as a cure, or to say that it can be given to anybody at any time. As we know now, it's really only effective if you give it very early on. By the time you go into the second week, the immune system is way too far gone for monoclonal antibodies to be effective. And so that kind of reporting, I think, can also be extremely valuable in a pandemic when people are hearing all these very big messages delivered from very big platforms. And as I mentioned earlier, I've seen my role in so much of this pandemic as debunking some very, very wrong information and giving a sort of reality check for what we can actually hope to see from this virus and what treatments will be effective and, what we can expect to see in terms of the immune response long term and things like that. So, again, I think for all of those things, for me, the most valuable resource is the human resource, has been scientists who are willing to give me time to look at preprints and vet them, to say whether something is worth covering or not, to make time to talk and put things into context. And I'm really grateful for all of the sources who have made time to do that.
Great. Thanks so much, everyone, for your insights. I'm wondering, as some of the questions roll in, and I invite everybody in attendance to send your questions in, we'll get to as many as possible. And I'm wondering maybe if we could just start out, if each of you could tell a personal story from the pandemic, something that really touched you, that really resonated with you, that when you look back 20 years from now, this will be one of the things that you remember. And I'll let you jump in whatever order you prefer.
I can start with I'm not a doctor, so I don't have those kinds of stories, but I did interview this woman who was pregnant back in April or May, and she, couldn't bring her husband in with her because this was right at the height of she was actually giving birth in late March, even though I talked to her in April, and she couldn't bring her partner in with her because of the rules. And so she was met at the lobby by the nursing staff, and they told her that she couldn't even bring her friend with her. And so she ended up being ushered into a room. And because the nurses were so, short-staffed and they had so many patients to look after, she ended up laboring in a room by herself for hours at a time. And then, even when she gave birth, they talked about taking her baby away from her. This was very early on, remember, and people didn't really know what to do, whether it was safe for a woman to have her newborn with her or not, whether it was safe to breastfeed or not. And so they actually wanted to take the baby away from her, and she had to have her, midwife argue for keeping the baby with her. But that entire story, as somebody who has gone through giving birth twice, I really was harrowing to hear her experience of having labored alone for, a good part of a day off and on.
I have one from maybe my second or third patient I saw, and it struck me just because this is kind of getting early experience with this virus. And it's like a 60-year-old man who was an accountant. And if you remember, COVID hit right before the tax deadline. And he had a little bit of a fever, he was short of breath, he was on maybe 2 liters of oxygen, which isn't that high. And he was sitting in the bed, working on his accounting stuff, just on his laptop, just pounding away, taking conference calls, just like you would expect a busy accountant to do. And I said, well, you tested positive. This is before remdesivir, around the time of hydroxychloroquine, before steroids. And I said, we'll see how you go. You look okay. You've got pneumonia on your x-ray. Your oxygen levels are okay. You're able to go about your life, and you're doing things pretty well. And he's like, well, it was a Monday. And he's like, well, I'll be here past Wednesday because I have too many meetings. I have too much stuff going on with tax season. And I said, well, maybe you can't be around people, because even if you got better, you're going to have to self-isolate for at least 10 days or so, but maybe you can do those all virtually or phone call meetings. And he was like, okay. So I left on that Monday, and I came back on Tuesday morning, and I looked for him in the room. He's not there. He's in the ICU, prone, paralyzed, on 100% FiO2, the highest level of oxygen. And he stayed in the hospital for maybe 6 or 7 weeks. And that was, from my perspective, that was like, it's like watching some monster devour something. It was just a ferocity, because I had taken care of some cases before that, which were somewhat mild, but that was the first time I saw it rip through somebody. And it kind of got me a little bit, when you see these patients, they look okay 1 minute, when they're not into that second phase that Apurva had mentioned, that it can get very, very bad very, very quickly. So you have to be very cautious about what you say to patients and what to expect. And I mean, just from somebody who loves infectious diseases and almost likes infectious diseases more than people, that to see that kind of that ferocity, just to see it just the way it just took off in that patient was just like it was just very eye-opening to me and very, very startling to see, because I had not seen something. I've seen sick patients, but nothing that had like flipped a switch like that, and it was just very, very, very interesting, and that made me gave me a lot more respect for the virus than I had back in March when I had been just taking care of mild cases or cases that you'd expect to be bad, but to see it just do that all of a sudden was very interesting.
Thank you, Amish. Nisa?
Right after we had the biocontainment unit open from March 1st through March 21st, and at that time, the turnaround time for testing was, 5 to 7 days was incredible. But right after we closed and we sort of rolled this out to the other units, we had a patient one night in endoscopy, and we had to transport him back to the inpatient unit where he was staying on. And, the transport team said, we might not get there for an hour and a half. And I said, look, I can transport this patient back. I've been doing this for the past 3 weeks. I'm okay with this. And one of my nurses said, I'll go with you. And I was really like, oh, no, I don't need that. And I was like, yeah, sure. Let's go together. The transport route through the hospital back to the inpatient unit took us about 45 minutes, which is usually a 7-minute transfer. So in that 45 minutes, this man went from not needing oxygen to being on 4 liters by the time we got him to the floor, which is tremendous. And I remember saying to the inpatient nurse, who happened to be my preceptor, she taught me as a nurse years ago. And I said, Stacy, remember when you told me to just look for those little things that aren't right? I said, this isn't right. Now, at this time, we had taken him to our unit to test him to see if he was COVID negative or COVID positive. So we really didn't know if, what his status was. But my gut just said, you know what, this is not going to be good. And I said to her, please make sure that you assign him a nurse who's going to watch him the way you would. and be in there, every couple of hours and checking on him, because again, that was such a shift. And to Purva's story, his wife couldn't come in. This guy was, we spent 45 minutes together, so I began to know the story of his life. And I remember saying, why don't you let me call your wife? And I'll tell her where you are, and I'll tell her who's taking care of you, and I'll give her my number. And that way, if she has any issues, I can help her navigate this system. And he said, oh my God, that would be wonderful. And here, this is a big, tough guy who now has not being able to breathe. He's got a lot of air hunger. You can see the anxiety increase. And his wife and I spoke for the next 5 days he was in the hospital. I said to her, look, if you don't get the answers you need, if you don't feel like someone's talking to you, call me, and I will figure this out for you, because I couldn't imagine that being my own family member, but I also knew how challenging it was to bring another vector of infection that's out in the community into this environment. We have to make difficult decisions every day to protect our staff. And I talk to these families all the time. I give them my number. I make sure they know how to reach me, because, again, navigating the system and worrying about your family member overnight is huge.
Great. Thank you, everybody, for these stories, because I think that lends its own power to testify to the reach and the impact of the epidemic. I'm going to go to the questions now. The first question is does the pandemic itself slow information about potential treatments and delay their innovation? The suggestion is in terms of fewer in-person meetings, less time in trying to stay up to date on information, other obstacles that the pandemic itself causes.
I can take a stab at that. So I do think it definitely, we do have, at one side, in one sense, we have so much information every day that I wake up and there's so many emails that I have to look through to see what's going on. But how much am I, reading, medical journals, like, I've got the new JAMA, I haven't read it yet. There's those types of things I don't have as much time for. And the Infectious Disease Society of America meeting, which I love, it's like my most fun time of the year. I'm kind of a nerd, so I get very excited when that happens every year. It was all virtual this year. And it was hard because I kept getting press calls during it, so I couldn't watch all of this stuff. And when it's online like that, it's much harder to actually engross yourself in it the way when you're physically there. So I do think, in that sense, it has made it a little bit difficult to keep up with everything that's going on, because there's so many things, and you just don't have the time, because it's coming at you 100 miles an hour, and you don't have these dedicated meetings where you're kind of away from all of your other responsibilities. And, I still have to, I kind of dread how many lectures I have to listen to at ID Week on my app to see how to get back up to date from, not just for COVID, but for all the other infectious diseases that are sort of getting a little bit neglected in my brain right now.
Thank you, Hamish. Apurva, this question is for you. You mentioned how difficult it was at times to talk with doctors, frontline doctors themselves, being kind of blocked from that. And this question is, does that apply to government agencies? Have you ran into that in terms of federal, state, local agencies and kind of the withholding information? A recent HCJ survey, the writer says, indicated reporters are often blocked from speaking with these experts.
Yeah, it's an excellent question, and it's very true. The FDA and the CDC and the HHS have all been completely closed off, really, to reporters for the last few months. It's gotten to a point where I don't actually bother most of the time to ask for interviews, or if I do, I know that I have to, and so I do, but I don't expect them to respond. But I will say, the way that the CDC has acted is, in terms of communicating with the press, is not completely new. I mean, it also was like that during the Obama administration. It's just that at least during the Obama administration, we got to talk to people about things that weren't really sensitive or political in any way. But, who knows how it would have been if with a situation like this. I mean, during H1N1, they were a little bit more open. But yeah, I mean, the CDC and the FDA have been extremely difficult. My colleagues and I, who report on these agencies, have had to rely a lot on anonymous sources, which isn't something the Times likes to do. But when you don't have a way to get information any other way, so we have pretty strict rules about who the, using sources like that. We always clarify that the sources didn't want to talk for, what reason. Like we specify the reason. Often in this case, it's because they didn't want to, didn't want to lose their jobs. Or in the case of the CDC, often it was because they didn't want the administration to get even angrier at them and maybe, cancel the CDC the next morning. So often, we've had to talk to people, but I want to sort of make a clarification there. I think probably not true for anybody who's listening, but just in case, anonymous sources doesn't mean I don't know who they are. It means I know who they are, and not only do I know who they are, but my editor and my editor's boss, so the head of the desk, both know who they are. So, I have to be very transparent about who my sources are and where my information comes from. I just protect them from being publicly revealed.
Great, thank you. And this next question is on dexamethasone and its cost efficiency. And do you see other relatively common low-cost wellness and supplemental treatment approaches as possibilities, including elderberry, vitamin D, and zinc? The latter two were given to the president during his Walter Reed stay.
I suspect that's for me. Because, dexamethasone is very cost effective. It is a cheap drug. It can be given orally, it can be given in a liquid. We give it all the time for many different other reasons. And it's not just dexamethasone, it's any kind of corticosteroid. So even prednisone, which we give to lots of people for anything from an inflamed knee to poison ivy can be used. So this is a very cost-effective therapy when you think about how much mortality you're buying with it. So yes, that's true. So when it comes to the supplements, there's not very much data on any of them. I'll just take two of them. Vitamin D, I do think that there is data that vitamin D deficiency. So we have a vitamin D deficiency sort of epidemic in the United States where many people have lower than normal vitamin D levels. And we know that that has an important role to play with your immune system, and that people who are vitamin D deficient are more likely to get respiratory infections and more likely for them to be severe. So it is important to make sure that everybody has adequate vitamin D levels. And there are countries like Scotland, for example, where they're sending supplements to their population as a COVID preventative. And I think that there's science behind that. The data doesn't show, though, that if you are ill, that taking vitamin D supplementation after you become sick has any kind of benefit. So I wouldn't recommend it in that situation. But overall, I think the higher the vitamin D levels are, the better. Zinc is something that has a little bit of controversy. Several years ago, there was a very famous study where they looked at people with a common cold and gave them zinc and saw whether or not it decreased their duration of symptoms. The data is mixed, and it is, some of the data is positive. Not the zinc the nasal spray, because that was actually causing people to lose their sense of smell, which is kind of coincidental because COVID does that as well. So people were using zinc lozenges for cold types of duration. I tried it a couple of times on my own just for the fun of it. I don't really like the taste of it, and I don't think the taste of it is probably worth the duration drop of a day or so that you might get. But I don't think that there's any strong data to use it. I don't mind if people are using zinc because there's certainly much more dangerous things they can use, but I don't think there's strong data that it works. And then I don't like the fact that zinc got kind of sucked into this hydroxychloroquine vortex, that people would always have a negative impression on any kind of hydroxychloroquine study because it didn't include zinc or because it didn't include azithromycin. So I think that you get down a slippery slope when you start talking about zinc because it's become the subject of conspiracy theories now. So.
Great, thank you. Let me just follow up on that, Amish. It seems like the sort of process has been trying approved drugs and applying them against COVID, and then trying, kind of more experimental drugs and going from there. And is that how would somebody think to apply hydroxychloroquine in this situation? A drug against a parasite. How does all that happen?
So hydroxychloroquine for a while had been studied just because of the way it looks, I guess, chemically against many different viruses like hepatitis B, HIV. So some people have been looking at it as an antiviral because there are certain drugs that can be repurposed and might have some impact. And we know that when you have an infectious disease, it's always an interaction between the immune system of the host and the infecting organism. And that immune modulation has become something that we try to do. And we do it very crudely with steroids like we're doing for COVID-19. We do steroids with pneumocystis pneumonia and HIV, for tuberculous meningitis, for regular bacterial meningitis. We use steroids. So people have been trying to fine-tune the immune response, and hydroxychloroquine was one candidate that people looked at because of its role in rheumatoid arthritis, because of its role in lupus, and because it had some in vitro activity. That's where it came from. And then people started looking at it and doing trials, and there was mixed data or anecdotal evidence, and it was very hard to interpret for the general public and the press. And obviously, people wanted an easy solution. This would be great if you had an over-the-counter drug that people had a lot of, not an over-the-counter drug, an approved drug that everybody had a lot of experience with, that could be used off-label, and it was available orally. We had big supplies of it. There was major donations being made to the United States. It would have been great if it worked. I think that's kind of the misnomers. Many of us that were critical of hydroxychloroquine, we said, we didn't want it to work, or we all wanted it to work. It would have been awesome if it worked. I think if we would have had positive data from hydroxychloroquine, this could have changed. It would have been something that would have been game changing. So none of us wanted it to fail. We wanted to know for sure if it worked, because we were giving it to patients kind of on an ad hoc basis and not knowing. But again, sometimes that's the jump from in vitro to in vivo, and it's not always going to be the case, because all kinds of things can kill the coronavirus in a petri dish or in a cell culture, but how many of them can do it in the human body?
Great, thank you. Nisa, I want to go to you now. You talked about increasing the resilience of nurses and the challenges there of that kind of day in, day out work, and seeing patients and how devastating this illness can be. What does that look like? How do you build resilience? How do you help protect them against depression, PTSD, and all of that follow-up?
One of the things that we have done are start with building the physical capacity, making sure that the staffing ratios are safe. Somebody isn't taking care of 7 patients. We really downsized our staffing ratios, first of all. Then we made sure that we built into our daily work a lot of breaks. And that's something we learned from the biocontainment unit. In the biocontainment unit, it was like a ballet. You wrote the time that you went into the room on your PPE, and someone was always looking to say, you've been in there for an hour and 30 minutes, it's time to come out. And we did that a lot on our COVID units. And we would say to people, you're going to take a 15-minute break right now. You're going to get all out of your PPE, and you're going to go sit in a space away from everyone else. And we commandeered every single space we could possibly have to do this, so that units would have this rest area, this respite area. And then we were very structured with the way we took lunch and things like that. And that's very unusual in nursing, because I got to tell you, most of my nursing career, I've been standing up in the break room, eating lunch as I'm talking to the physician, 5 minutes, right out the door, right? And to have this concept of you are going to leave the unit, you are not going to be in touch by phone for 45 minutes or an hour, whatever people could do, was really good for staff. They really liked that. The other thing that we did is that we developed a lot of ways to communicate with each other as a group when we weren't on our home unit. One of our nurses came up with Slack, a Slack group, and it just took off. I mean, and every day we'd be sending pictures of, I'm posted on this unit, this is what I'm doing. We draw pictures on our PPE. Again, a lot of things to keep us, still connected, because these are people that have worked together for 30 years, and now we're out in a different environment. We did a lot of food in the community. I think most of the COVID pounds came from us at Johns Hopkins, because every day there was, a new load of cheesecakes. It was actually really great. And the staff began to feel like they were taken care of. And that was really important. And, I would have this model where I would be there in the morning to get them on the bus. In the middle of the day, we would run a snack cart around to our different units just to be able to touch someone and say, I care about you. I couldn't even go into the units. But it became this sort of model that people would do. And then at the end of the day, I was there to say, how was your day? I'm really proud of you. Make sure your PPE is away. It was exhausting for my part, but I wasn't taking care of, patients in full PPE for hours at a time. I've done it on the biocontainment unit. I know how difficult it can be. So those are some of the things that we talked about. We also we're very open about our employee assistance programs, FASAP we refer to it as. And I encouraged employees to get involved and to reach out and to talk about those things you can't talk about at home, remember, I can't go home and talk about what my patients have done, right? I can't talk about it to someone else. It's very internal. So to find these places that are safe and confidential is very important. I also made a point to take a course with Cinda Rushton about stress and resiliency. And that was very good because it really enabled me to look at how different people manage stress and to be able to help them manage it. Especially, our nurses are one thing, but, you talk about a lot of our ancillary staff, right? They come from environments that may not be all that stable. And then drop a pandemic on top of them, and we're going to cut your hours, and we don't know where you're going to work. It's just all of these stressors combined. And to be able to create that space for the unit was really important. And as we came back, we developed this theme of we've all been in the same storm in different boats. And I would encourage people to come back and tell their stories, either at our daily huddle, what they remembered, those types of things. So it became your history, but you could move forward from it. And those stories are so important.
Great. Thank you, Nisa. Apoorva, a question for you. For journalists focused on holding readers and institutions accountable, state, local governments, hospitals, et cetera, what should we be looking for during the current wave?
I think you should question everything all the time. Okay, so I will say I'm working on a story right now, for example, that really questions this idea that we've been hearing everybody talk about, which is that social gatherings are what is driving this new wave. There's no question that they contribute, but are they driving it? Are they the engine? I don't know. We'll have to wait and see in my story. But I think that's the kind of level at which we're operating, where in this pandemic, somebody says something once, somebody else says it, before you know it, 50 people are saying it, governors are saying it, Dr. Fauci is saying it, and then, okay, once Dr. Fauci says it, it must be true. But really, it's important to ask at every step, what is that based on? What is the data? What are the numbers? And do they support these statements? So I would say that's the level at which we should be operating. I think it's been a little bit challenging, especially during this pandemic, because we as science journalists are used to somewhat taking the CDC and the FDA and organizations like that for granted, but we absolutely cannot. And I don't think we've been able to during this pandemic, and I think it's a good lesson to remember that we really shouldn't even going forward. I don't think that should change. I think even when the Biden administration is in power, even if they're doing things in as transparent a way as possible, we should continue to ask really tough questions, follow the money, follow the data, and examine everything.
Great, thanks. And I'd be curious to hear from you, Apoorva, and Nisa, and Amish as well. How would you rate the coverage of the pandemic and what journalism has done with it?
I mean, I'll say that, it's hard for me to rate myself here, but I think that overall journalists have done a really good job. I mean, at the times for several weeks and months even, the entire paper was dedicated to covering the coronavirus, and people were writing about things that they really have very little expertise in, which can be daunting and scary and challenging, and they just, reached out, asked a lot of questions, asked for the right experts to talk to, and really tried their best. There's a lot of crap out there, but there always is a lot of crap out there. And I think the bigger and more sort of credible outlets have done a really phenomenal job. And I'm so proud of science journalists for how we've kept up with this pandemic.
Nisa?
I would completely agree with Apoorva. I think it's really interesting to see how this has evolved. And there is junk out there. There are some people that would reach out to us at Johns Hopkins, and we'd say, we want no parts of that. We don't want our name associated with that because we have credibility, right? We want to maintain. And I think I really liked what you said about asking those tough questions because that's really important. I know that, the demand for someone an expert from Hopkins, and I'd always say, be really cautious about that because, let's be clear about who is an expert and who is not. But I do think that good journalists have done a really good job of getting this message out to the public. And, they're really the boots on the ground, right? I can stand up every day and say it to 100 people, but, what Apoorva can do with all of her media outlets is huge. And again, getting that good, fact-based, data-driven, questioning message out to the country is really important.
I would agree with that. And I would say, as someone who's been doing media and infectious disease for a while, I think my first time was in 2007 about herpes in wrestlers. Was the first time I was quoted by a media outlet at a high school match for herpes. So 2012 was Ebola, the Ebola outbreaks, in 2013, 2014. I think that the scientific press has gotten much better from that time, because I can remember during Ebola just shooting down a lot of, even from big places, sensationalistic headlines. And I think with COVID-19, I think that they've really come into their own. And I think that science journalists like Apoorva, like people at STAT, they've become kind of celebrities in their own right. People, even in my field, look to them to see their interpretation of things, because you almost end up treating them like peers because they're so enmeshed in the data. So I do think that there really is a real value in having dedicated science journalists that follow this the way someone taking care of the patients do. And I think, I read all of these articles, and they're not always all journal articles in medical journals. Sometimes they are from the New York Times, where I'm actually learning things or using it as a springboard. And I think, so I've been very, very, very pleased with the way that the media has handled all of this, even when there's something where they're pushing back on something, or they may not disagree, or they have a preconceived notion. And there are reporters that I know I've got to reply to one right now on my email that has a very slanted question that they're asking me. Most of them have been receptive when you sort of reframe it and say, well, no, it's probably this is the case. And I think, some of that, so I do think it's been really helpful to see the journalists engage in this story the way they have, and to allow the science reporters to rise to the top, because in Ebola, it was science reporters and then the general reporters. And you could tell there was a total shift in coverage when the general became a general story versus a science and health reporter story. So, I tend to value the science and health reporters a lot, because they do add a lot of context.
Well, I hope that means that outlets are going to hire a lot more science reporters on staff, because there are very, very few out there that have dedicated science reporters, and we clearly need them.
Okay. Here's another media question. Does aggressive media coverage of preprint results make your jobs more difficult as healthcare providers if patients have strong opinions on how to manage their treatment? So, Nathan, I don't know if you want to start, and then Amish.
Yeah, my gosh, I've seen this even before COVID. We used to talk about patients coming in, they were positive for a binder, and they'd have a binder full of all this information. And it's gotten worse with the pre-press. And the interpretations are very interesting. I get this. I had someone called me about the nursing home study in France, where they actually locked the staff in the nursing home, locked them, but they kept the staff in with the patients for, a couple weeks at a time, and that seemed to reduce the COVID spread. And I thought, boy, that'd be an interesting concept here in the United States. So, I think there's a lot of pressure, and I think there's a lot of pressure to get the story as soon as possible. And I'm not a journalist, so I can only imagine how difficult it is to try and get accurate information as soon as possible and be the first one on the story. But the preprint has been very interesting.
Yeah, I would think the preprint makes it a little bit harder for all of us, because we know that some of those are never going to see the light of day when they get through peer review, but yet they're getting reported on as fact, and everybody is breathless about some study. And you have to sort of take the wing, take the wind from their sails a lot with preprints. And some preprints are good, but some are not. And it's even hard for me to keep up with them all, because there's so many being uploaded that I don't know which one's contradicting which, and then I don't remember what happened to that preprint. Did it ever actually end up in a peer-reviewed journal? We never know sometimes whether that actually happened. So I think that preprints, they were responding to the fact that you need to get information out very quickly, and that peer review processes at top journals take a long time. But I do think it's made it much more complicated. And patients are reading preprint stories in their local newspapers, and it's not, that context isn't there. And one interesting, funny thing was, all the hydroxychloroquine. I had a patient that I had to consent for remdesivir on emergency use authorization, and he had confused remdesivir with hydroxychloroquine, absolutely did not want it, because the president had advocated hydroxychloroquine. So I had to convince him that remdesivir wasn't the one the president was talking about. So you can get all kinds of interesting anecdotes from people, from the general public, how they interpret stories or half stories that they've read.
And that's just the perspective of a science reporter, though. I appreciate that you can appreciate the position that we're often in, but I think, especially as the pandemic has gone on, it's been more important to be right than to be fast, which is one of the mottos of the Times, really. And I cover preprints a lot less than I used to in the beginning. I think everybody covered a lot of preprints because the journals just couldn't keep up, but now the journals have gotten faster at doing their own review and getting things out. I only really cover preprints if I recognize the researchers, if I know the lab that it's coming from, and I try to do my own kind of peer review, sending it out to scientists that I trust, and if they say this looks good, the data are solid, and if there is enough data in the preprint to begin with for them to be able to evaluate and say it looks good, then I cover it. So I won't say that I've stopped covering preprints. I understand why they're tricky, but I think we can still cover them as long as we're careful, because the review process is still often too slow for when we actually need information.
That's terrific. Thanks, Apoorva, for sharing the journalist viewpoint. Amish, I was curious too. You mentioned kind of you're looking at preprints and everything like that. What are you looking for, and in terms of what will you pay attention to when you're looking at a preprint?
I look to see who the authors are, where it's coming from, just like Apoorva said. I like to look at the biological plausibility of what's going on. And as someone that's in the field, I try to look and say, does this actually make sense from a physiological or biological point of view? What are they trying to show here? And then I try to evaluate it as best as I can, as I would evaluate any journal article. It's just that there's so many of them that it's hard. But I think to me, it's always biological plausibility, because lots of things can get published where it's some spurious thing, where it's correlation and not causation. And that's part of being able to evaluate scientific literature that comes from experience of looking at these papers and seeing things get retracted and seeing things, reading the letters to the editor inside the New England Journal or JAMA, where people are picking apart, or sitting at journal clubs when you're a resident and fellow. But I do that same type of thing. But biological plausibility is the first thing I try to look at.
All right, as well as like the size and the number of participants.
Yeah, that's all part of it. If it's 4 people, that I look at sample size. I look at what was there a placebo group, all of that. The same type. That's kind of what I meant by the journal club stuff that they teach you when you're in residency and stuff, is how to look at a paper and understand how valid its conclusions are.
Great. This is a great question. Are there any treatments in development or clinical trial stages that you are particularly interested in? And I'll just open that up for you.
I think there are some immune modulators that move a little bit upstream. Apoorva went into great detail about IL-6, but move a little bit upstream that we might see something. There's something called JAK kinase inhibitors. I don't know if Apoorva has written on those, but there's some okay data there that's coming out. I don't know if that will end up being something that ends up panning out, but I think it's important to remember that all of these interesting immune modulator data, that's what everybody likes to hear about and write about. It's only a small fragment of the population. I would be much more interested in a Tamiflu equivalent, something that prevents people from having complications or needing to come to the hospital, that's not having to be given in an infusion for over an hour. And there was an interesting paper just a couple of days ago on fluvoxamine. I don't know if you guys had heard about that. That's an antidepressant drug, a serotonin reuptake inhibitor, an SSRI, that showed some benefit in preventing people from coming out of going to the hospital. And they did it. It was a no-touch randomized double-blind controlled trial where people had, when they were diagnosed, they had packages shipped to them, and they took either placebo or that, and they seemed to have good data. It was published in one of the JAMA journals. So I think that's interesting. I think that would really be, that's the therapeutic. There's all this fancy immune modulator stuff with all this precision-guided medicine, but if we could have something that could be easily taken at home and stop you from needing to be hospitalized or make you less contagious, that's what I would be excited about. And if that antidepressant pans out, that would be great, but I don't know if it will.
Apoorva or Nesa, any want to weigh in on anything that's in the pipeline that looks promising to you?
I think I agree with Amish that antivirals are really where we need to be. I think that there are a lot of immune modulators, and I don't know how useful any of them will prove to be ultimately, but I do think that antivirals are where we need to go for early stages, because a lot of the drugs that are out there have to be timed exactly right, are only for severe patients, or only for people who are in the ICU, et cetera. And so we need something that can act quickly and prevent disease. And obviously, monoclonal antibodies are sort of one of the things that are being proposed to be used in that way, but we don't have nearly enough doses of that. They're very expensive to produce, and the manufacturing capacity for those just isn't there for the number of doses we would need.
Yeah, and I'm going to echo the operations standpoint. I mean, really, if you think about COVID testing, right, now we're doing it in these tents. You drive up in the car, it's fast, it's quick, it's got good turnaround time. You need something along those lines that don't require, a nurse to have to manage 5 or 6 infusion patients at a time, that we know is safe, that they can do at home. Again, Tamiflu, I think that's a great analogy. I mean,
great. And we've heard so much in the last week about vaccines and vaccine progress. And in some ways, kind of surprising that, that the vaccines seem to be landing in really encouraging, so quickly. And I was just kind of curious on sort of your takes on that. Is that typical? I would think we would expect to see a medicine, a drug delivering sooner than a vaccine because of the challenges in terms of a vaccine and giving a vaccine to someone who is not sick. But wanted to hear your takes on that.
I assume that we would have medicines before vaccines. Vaccines are usually a process that's measured in years, not in weeks or months. Although we have went lightning fast with these vaccine candidates. The first things that are easy to make are try to repurpose. You can repurpose things, and you can make monoclonal antibodies very quickly. And even remdesivir is something that was repurposed from Ebola, so that makes it easier. And remember that, like what you said, when you're giving a vaccine, you're giving it to a healthy person. So the risk-benefit ratio really has to be perfect because you don't want to make somebody sick that's healthy by giving them a vaccine. So you have to be much more meticulous with your development of that versus an antiviral, which you're giving to somebody that's already sick. So the risk-benefit ratio is already altered because you're not giving it to a healthy person anymore.
I mean, I talk to a lot of immunologists all the time, and I have to say, I think a lot of them were cautiously optimistic that this is actually what we would see. I don't know if they expected 95%. I think everyone's kind of blown away by that, but there was no reason to think that a vaccine to this virus would not work well. And I'll give a little plug for my own story. I just published a story right before this panel about how immunity to the virus now we think lasts years, maybe even decades, which is a lot longer than we thought. But again, that is another thing that may seem surprising, but actually immunologists have been cautiously saying that really since the beginning. And we've seen very long-term immunity to SARS. People who survived SARS still have pretty strong levels of T cells in their blood 17 years later. So why would this be different? And so I think based on information like that, it seems like vaccines are generally better than natural infection at producing a pretty strong and durable immune response. So I think the optimism has been there somewhere underneath all of the worry and caution about this virus.
One thing that's important, I think, that's interesting is that we have coronavirus vaccines for cattle and for poultry, and people forgot about that as well. Because I remember being on calls and like, we have them, really, and nobody realized that veterinarians have been vaccinated against coronavirus. So I didn't think there was going to be an obstacle to getting a coronavirus vaccine. It was the speed and seeing if these new vaccine platform technologies like mRNA panned out when they actually were put to the test.
And Apurva, another journalism question for you. This one says, what do you look for in a source you trust, from doctors to scientists? This is from a non-science reporter.
I look for caveats. I love caveats. I get very nervous when a source, maybe, for one paper, a source might be very enthusiastic because the paper is really that good. But the majority of the time, I'm hoping and expecting that they're going to spell out all the ways in which the finding isn't quite a slam dunk, because that's what I really need them to point out to me. I'm very wary of anything that seems like a breakthrough or a miracle or best news ever. Although the one I wrote today was kind of like that, but those are rare. And the vast majority of papers will be delivering something incremental or something, potentially exciting, but with lots and lots of caveats. So that's what I need from it. And I also think it's very helpful for them to be available. That's the other thing. It's not useful to me if I'm on breaking news to have somebody want to talk to me 3 days from now. I need to talk to them within the next, 40 minutes. Hopefully, right away.
And what are you looking for when there is something that seems almost too good to be true? What persuades you that you're going to follow through with the story you're talking about today?
Well, again, that's where the experts come in handy. I talked to, for this particular story that I wrote today, I talked to some of the best immunologists in the world, and they all said, this is totally plausible. This makes sense. This is what we really kind of expected. And when I hear that, then I'm ready to go forward. And of course, my editors were nervous as well. And they said, can we really make this claim with, these many people, whatever the case is? And I want to be able to go to them, having asked all the tough questions of my sources, to say, yes, absolutely, Akiko Iwasaki or Dito Bhattacharya or whoever, whichever immunologist I've spoken to before and really trust their expertise, I want to be able to say, yes, they believe in this work, and so I think we can take this to the bank.
Great, thank you. I wanted to shift the question a little bit now to the COVID long haulers, the people who are suffering, kind of extended effects after, supposedly recovering from COVID. And I'm just curious about your thoughts on treatment for them and what that would look like. And are we looking at, damage that has just been done and is not reversible, or what kind of different treatments would they require?
I think this is a very hard question to answer because we don't know the answer. We don't even know if they're all homogenous, that everybody that's a long hauler has the same pathophysiology or the same physiological derangement that's occurring. Because lots of people are getting lumped into that, and we don't even really have strong diagnostic criteria. So the treatments, I think, are going to have to be very individualized. And the first step is actually being able to define this syndrome much better than what it is defined as now, so that we can know. Because I've had patients like this, and you do their blood work, it's mostly completely normal. There's no chest X-ray problems. They don't have oxygen problems. Their heart function is normal, but yet they can't get back to their activities of daily living. And I don't know how to categorize that or even how to define it, because everything looks normal from a biochemical standpoint. So we really need to see the data from those registries that are going on in places like New Jersey and Mount Sinai to be able to tailor a treatment regimen for these people. And other infectious diseases do have these long haul type people. Lyme disease is the most famous one, where we have people who have post-treatment Lyme disorder, which we don't quite understand yet. It's a real thing, but it doesn't seem to get better with antibiotics. It doesn't seem to have any abnormalities in the blood work. And we've seen it with Epstein-Barr virus, which is one of the causes of infectious mononucleosis. So this does happen to some people, and I don't know what it would be. It'd just be my speculating that it's some idiosyncratic reaction that certain people have based on their comorbidities and their genetics to certain infectious diseases. Another good story idea, though, is to try to unravel that.
Mm-hmm. Mm-hmm. And Nesa, any thoughts from you in terms of from a nursing perspective and in terms of, getting them out of acute care, but then, needing care for an indeterminate amount of time?
Yeah, that's exactly what I was thinking, and as this population moves out to the community and we're depending on their family members to take care of them, and their family members are just saying, I'm exhausted. Like, this is the man who used to work 5 days a week, and now he can't leave the chair in the living room. He's just so tired. And the frustration that the patients have going to their physician and someone saying, oh, your lab work is right. Is this just in your head, right? So that's another very interesting piece of this. One of the things that we did, and we're going to do it this next way, is we developed this role of a COVID liaison nurse. And that was a nurse that was to go with each COVID patient and start to explain to them what would happen when they left the hospital, and explain that to their families too. And then wrap them up with social work resources early rather than late, especially in the marginalized communities. We had a lot of Latinx patients. We have a lot of, underserved populations. And we tried really to get nurses that were from those populations to be able to really connect and say, I want you to feel safe. And I want you to be able to report this. And I want you to make sure that you go to your doctor and follow up. Because one of the things that I noticed, and maybe this is just my own perception, is that a lot of people waited to get care in the first wave because they were afraid. They didn't know what to do. They didn't know if they had insurance, those types of things. So that's where finding services, and not just medical services, but social work and community resources for this population long term, is really important, especially if they have comorbidities.
So one of the things we haven't talked yet about is with treatments is access and distribution and how available. I'm thinking of President Trump and his sort of cocktail of treatments and all of that, and it seemed to work well for him. He said he was feeling better than he was 20 years ago. How realistic is it that the general population and everybody who gets sick will have that level of treatment, and how soon might that be?
Well, I would say the level of treatment is that having basically a full service hospital in your house is probably not achievable by anybody. Maybe the maybe Queen Elizabeth has something similar in Buckingham Palace, but it's not something that everybody can have that doctors waiting on them hand and foot. But I do think many of the treatments that he got, remdesivir and dexamethasone specifically, are standards, and we do give those. I give those to all my hospitalized patients, and I've not had an access problem. Obviously, he got the Regeneron monoclonal antibody cocktail, which isn't available to anybody right now. It's still in clinical trials. It doesn't have an FDA emergency use authorization, and we even for the Eli Lilly version of it, like we said earlier, it's still very hard to figure out how you're going to give it. So that part of his treatment did differ from the average person's. So I do think I think this speaks to the fact that we have adapted to this virus and we have protocols like Nasa said, that we can get people the drugs when they need them. And I think that's really a testament to the fact that we've seen improvements in care, and that's why we've seen decreasing hospital mortality rates. But again, that's all very contingent on hospitals not being inundated, because if a hospital is inundated, you may not get those treatments because nobody will even get to you because you're in the ER kind of buried underneath 3 other patients that are ahead of you.
All right, great.
One
Nathan,
question, actually, if I may. I know we went past that, but I wanted to just say that if there are journalists here looking for story ideas, I think one of the things that's been really undercovered is that long COVID seems to affect mostly women. And I think that's going to play out like very many other diseases where women aren't taken seriously and they don't get the care and they're dismissed as, psychological manifestations. So I think that's going to be very important and an emerging area to cover. It's also looking like maybe there's an element of autoimmunity to this virus, and I wrote about that a couple of weeks ago. But people seem to have autoantibodies like the ones that you see in rheumatoid arthritis or lupus, and those also are more common among women than they are among men. So that the gender element of long COVID is going to be very interesting.
Great. Thank you. And I'm going to, we've got just a couple minutes left. I'm going to go ahead and wrap up here with one more question. Would love to hear your thoughts on where are we going to be with treatment in a year from now? Nasa, do you want to start off?
I hope that we're in a much better place than we are today. We again, remdesivir has done, and things like that have done a really good, have had a really good run. I just think there's so much demand to find that, that treatment that can be done in an emergency room or in a primary care office that will keep these patients out of the hospital. I think that's kind of a silver bullet. I don't know if it's really there.
I think in a year, we'll probably have some way of keeping people out of the hospital. In a year, we'll have the vaccine, so the burden of cases will be lower. We'll likely have some concept of operations to give the monoclonal antibody. Maybe there will be an oral equivalent, or maybe the monoclonal antibody will be able to be given by subcutaneous injection so people can give it at home to themselves. I think hospital level care will be much, much better. We'll have a very precision guided approach where we know what's going on. We'll have very clear risk factors for understanding who's at risk for crashing. So we'll have a lot better triage decisions of let's admit this person to the floor versus let's admit this person to the ICU, or let's discharge this person home. We'll be much better at being able to do that and match people to the acuity need that they have. I do think we'll probably have some solutions to some of these cytokine storm issues. There may be some things that will eventually pan out. We'll be much, much more comfortable with the complications, understanding who's going to get heart problems, who's going to get a pulmonary embolism, who is going to have other vascular problems. I think the pathophysiology will have so much more detailed knowledge within a year that it will be something that people kind of get sick of. Medical students will it'll be so much intricacy of a new disease that they'll have to remember that they'll probably be sick of it because it's already magnifying exponentially versus other emerging infectious diseases. Like if I asked a medical student to tell me about Nipah virus, they would not be able to tell me very much about it.
Orva?
I agree with Amish. I think there's going to be a vaccine, and hopefully most of us will be vaccinated in a year's time, as long as we can solve the issues around equity and access, not just within the United States, but worldwide, because if there are people who are traveling a lot, and if they haven't been vaccinated yet, even if the virus isn't circulating at high levels here, they're still going to bring it back and get sick themselves. So it's going to be important to not just think about it as, America and America first, and that's it. But I think it will be a lot less severe. Hopefully, best case scenario, we'll be doing postmortem analyses of this pandemic. What went wrong and what data systems do we need and how will we deal with the next pandemic? And rebuilding infrastructure and thinking about broad spectrum, drugs, monoclonal antibodies that work not just against this virus, but against all other coronaviruses, things like that. I think hopefully we'll be at pandemic response 2.0.
Fantastic. I want to thank everybody, all of the panelists. You've done a wonderful job. It's been a great joy for me to be listening in and to be able to ask questions. And I want to thank everybody who sent in a question as well. So we're going to shift now to the breakout rooms, and I'm going to hand that off to an expert who knows how to do that. So thanks, everybody.